Good evening, everyone. I'm Dr. Vani Pujari from Salem chapter of TAPISAR. So we regularly have journal clubs once or twice a month. So today we have a very interesting article. It is on unexplained poor responder, like Poseidon 1 and 2. Like, we think that they're all right and we calculate the dose and start, and then suddenly there'll be a shock that we don't get the response we expect, and how common is it and how to deal with it. All those factors have been extensively discussed in this article. We have a very nice doctor and who is always researching, Dr. Siddharth Nagi, taking us through this article. Siddharth.
I'll share my screen.
Yeah.
Is the screen visible now?
Yes, yes, yes.
Yeah, good evening, everyone. Today, I'm going to talk about this article, which is a review article, basically, which is titled Management of Women with an Unexpected Low Ovarian Response to Gonadotropin. So this is a review article published in Frontiers in Endocrinology, which is a very good journal. And the authors are all very senior people in Poseidon group, and they have researched this area very widely, like Alessandro Conforti, Sandro Estes, Danilo Simadomo, Alberto Vairelli, Francesca Di Relli, Filippo Maria Ubaldi, and Placido Zullo and Carlo Alvisi. So the article, the review was prepared mainly in Italy, Brazil, and basically, and we can see the prominent people like Sandro Estes and Carlo Alvigi names mentioned here. So what is Poseidon? Poseidon, instead of complicatedly understanding about the various criteria of Poseidon, basically it is like this. It takes the age and it takes the results of functional and biological awareness of markers such as AFC and AMH. And it also takes into consideration ovarian response, the number of oocytes retrieved in the previous cycle. So these three factors the Poseidon takes and stratifies. The stratification we all know and we have all been hearing for quite a long time, but the basis of that classification is this. So understanding this classification in terms of basically all Poseidons are low prognosis groups. So understanding this classification in this article, they understood, they classified this, regrouped these four groups as into two groups basically. The upper groups, group 1 and group 2, they are the women with normal ovarian result. They define the normal ovarian result like AFC of more than or equal to 5 and AMH of more than or equal to 1.2. So when there is a low ovarian response in the women who are having a normal reserve, then that's something called unexpected low ovarian response. So that is what this review focuses on. And already when the ovarian reserve is low, be it the woman is younger or older, but the ovarian reserve is low, the poor response in them is expected. So group 3 is group 3 and group 4 are the women with low poor ovarian reserve. And only thing is group 3 they are younger women and group 4 they are older women. But these 3 and 4 are women with poor ovarian reserve. So they tend to respond poorly. That is known. But what is not known is which of the women in group 1 and 2, because they appear just like any other women coming to you for IVF. But when you stimulate them, they tend to have a poor ovarian response. So they subclassified the group 1 and group 2 women further as less than 4 as poor ovarian response, and 4 to 9 as suboptimal ovarian response. So be it whatever it is, so how to identify this group of women? And in case you identify them, can you rescue the cycle in which they are identified? Suppose you identify these women on day 6, can you do something about rescuing or salvaging that cycle? And going on further, whether there are any approaches to identify these women before ovarian stimulation itself. So once the woman has spent almost in Indian scenario, typically they spend on 1 lakh to 1.2 lakhs for ovarian stimulation, especially if it's a poor response. So at the end of all that, saying the response is low is not so much appealing to the patient. So whether we can identify them prior. So these are the challenges with group 1 and 2, and this review is focused only with this group 1 and group 2 women. So as I have told you, we are considering about the unexpected low ovarian response, that is groups 1 and 2 today. So first of all, so when we are saying this unexpected low ovarian response, there should be a definition. So though people who are doing this day in and day out understand what is unexpected low ovarian response, unless there's a definition, it's very difficult to form concepts. So they have got into the picture 2 terms called FORT and FOI, which I will tell a little bit later. But overall, the pathogenesis of this condition will be when you dose the patient lower than what they need to be dosed. So, this statement has quite a wider meaning. First of all, how do you know that they require higher dose is a bigger question. Then we'll discuss as we go. And there are some genetic or environmental factors. Correct, there are genetic environmental factors, but when we are going into a therapeutic approach or a clinical approach, how do we know that they are having a genetic environmental factors? Means I'm telling about the first ovarian stimulation they are going through. Second ovarian stimulation, we can do many polymorphism tests or as appropriate. Again, there's a lot of discussions on that, but still, first stimulation we don't know. And other thing is asynchronous follicular development. Though all these don't come into play, the people who are having poor ovarian response, they have early recruitment of follicle. They have low inhibin B levels, and they have a higher mid luteal FSH surge. Because of that, they have early recruitment of follicles. And again, not all follicles will be having early recruitment, and some will get recruited early and some will not. And by the time one reaches maturity, other will not. So this asynchronous follicular development in poor ovarian response patient itself can decrease the cohort. But anyway, we are not talking about them. We are talking about the patients who are expected to be having normal reserve. So in them, if there is asynchronous development, that can affect. And triggering issues, if the trigger and the pickup time is not proper, if the trigger didn't act, and so if it's an agonist trigger, those kind of issues can affect the ovarian response. Now coming specifically, so before going into the further, first of all, before knowing abnormal, we should know about something what is normal. So what is supposed to be optimal in an IVF cycle in a conventional ovarian stimulation? I'm not talking about mild stimulation, minimal stimulation, and other stimulation studies. Conventional stimulation, you should be able to get 10 to 15 oocytes, and this is given by Sunkara et al. And that will promises a higher live birth rate in fresh embryo transfer cycles. So I have already shared the objectives, the pathophysiology, to review the pathophysiology and to understand the available treatment strategies in Posidon group 1 and 2 patients. So now come to the FORT and FOI. FORT it measures the consistency between the pool of antral follicles at the beginning of ovarian stimulation and the pre-ovulatory follicles. So it doesn't tell about the oocytes, basically how many antral follicles you are seeing on day 2 and how many pre-ovulatory follicles more than 14 mm are there on the day of trigger. So this is called FORT. FOI is more practical because all FORT, you may say pre-ovulatory follicles, they can be inter-individual variation and all that. So, so FOI is the consistency between the antral follicles and the number of oocytes retrieved at pickup. So this is a little more practical than FORT. So they should be more than 50%, both FORT and FOI. If it is lesser than or equal to 50%, then it is called low FORT and low FOI. So why this concept is brought into picture is, so it is not the 4 or 4 to 9 oocytes what Posidon gave 4 and 4 to 9 oocytes in the previous stimulation to understand and to stratify them, but to understand the pathophysiology of exactly what is going on in them. So that is the reason. Suppose if a woman has 4 oocytes and she gets all the 4 oocytes, and the fourth is normal, and the FOI is normal, and if the woman has 10 oocytes and she gets 4 oocytes, definitely the FOI is abnormal. So these are the patients which we are going to specifically consider today. Suppose if when I have a patient with a AMH of 0.2 and 3 oocytes, and she holds on that she wants her own oocyte, and we stimulate them and she got 2 oocytes, then that is okay for her, because we know that the patient is having a poor prognosis. And what is not acceptable is a woman is having 8 oocytes and getting only 3 oocytes. So 8 antral follicles and getting only 3 oocytes. So this is what we are going to talk to us today. So it is the pool of follicles rather than the absolute numbers at the end of ovarian stimulation. Suppose I'm getting 3 oocytes, 4 oocytes. These discussions going on day in and day out among all of our colleagues. But what is seen before and what we are getting, this correlation is something which we have to take home today, which is very important for us. So for that, we have to consider some lottery numbers today. So that's the only way probably which we, otherwise telling all these numbers will be very boring. So these are not good lottery numbers. These are the unlucky lottery numbers. If you find these numbers, things are going to be bad. So it means that there are some polymorphisms which are found to affect the ovarian response. And if these polymorphisms are detected in the women before ovarian stimulation, we can develop the strategies to improvise them. And even if these polymorphisms are detected after ovarian stimulation, we can adjust the dose more appropriately. The second statement may not be more practical, because once you know that ovarian stimulation is gone, then we just try to push them. Because we are not practicing in the Western scenario, we are practicing in the hardcore Indian scenario. Whenever we see that the patient is suboptimal responder, we try to push her very hard. So, but anyway, this is for theoretical purpose. Even after the low ovarian response, the prayer cycle, doing this for polymorphisms can take us to more to a pharmacogenomic approach of dosing the patient more appropriately. And these are RS6166, RS108, 35638, and RS1394205. So these are the 3 major polymorphisms. The rest are all genetics. So it is replacement of ASN with serine and asparagine with serine and all this. So this is any polymorphism is a very smallest point. It's something like suppose if you take chromosome as a district, polymorphism is something like a home in a district. So it is something like a very finer genetics there, and it is not possible in the ordinary karyotype or all fish protein genetic test to identify this. We have to go for a Sanger sequencing or next generation sequencing. You should basically go for an array or an NGS to identify these polymorphisms by a PCR. So these are the polymorphisms, and these polymorphisms have been researched in various studies. Like if you take RS1394205 variant genotype AA had a lower number of oocytes and low pregnancy rates. Similarly, RS108-35638, it has also been studied, and this polymorphism is associated with significantly higher FSH and LH levels in both healthy and female infertility patients, and higher FSH consumption is seen in RS1394205 and RS6166. And this polymorphism, this is interestingly associated with clomiphene resistance, and the serine carriers seem to be less responsive to ovarian stimulation. So basically, these polymorphisms, when you are there, they have low response to ovarian stimulation, lower pregnancy rates, and increased gonadotropin consumption. That's what we need to understand. And before just going, let us not go biased with these numbers, because these numbers also should be interpreted in the context of the people where we are researching. So all these are Western studies, and these polymorphisms are shown very much prevalent in them. And it is not necessary that these polymorphisms will be prevalent in Indian women, but Indian women will have polymorphisms, but not necessarily these at these loci. So that is the problem. If you say for every patient I will do this in the routine package of IVF, you may not find them, but still the woman may be having polymorphism. That is the problem at the end of the day, which we have to think about. So these polymorphisms should be researched in the population studies, and genome-wide association studies should be done. Then only we can say that this polymorphism screening is recommended in this group of patients. So with regard to this work, with like a great honor, we should really honor Professor Ramaraju sir, who has done a lot of work in screening the polymorphisms of all the patients. Over 10-year data he has had about all the patients who are coming to his clinic. He has preserved the blood samples for 10 years, and then he has analyzed specific polymorphisms which tend to be common. They have analyzed a group of polymorphisms. They have gone down to narrow down to a few polymorphisms which are so, but this is only pertaining to Vizag and nearby place. But if you go for a larger group, like a South Indian population, this may not be very appropriate. So now how frequently you may encounter these patients? 10% of women who are actually found to be normal, they found to have suboptimal ovarian response in ovarian stimulation. But some studies have even shown 47% of the patients will go into posidone groups 1 and 2, and posidone groups. And specifically when you're talking about group 1 and group 2, group 1, especially when you are talking about young patients who are otherwise bound to do very well, around 5% of patients can have a suboptimal ovarian response. And elderly patients, 35% can have a suboptimal ovarian response in spite of normal ovarian result. Elderly patients, we all counsel, your age is more, so you can have a little more low response, and all this we say. But young patients, very difficult to counsel them, but it can happen in 5% of patients. So these 5% of women, we need to be very, very careful. And as the consequence of age, we tend to dose them higher. If it's an older patient with a normal reserve, group 2, which we don't know which is group 2, but we give a little more dose in them and we escape. But when you talk, and sometimes some people have a habit of adding LH also and we escape. But when we don't do all these things in a young patient who are having a normal ovarian reserve, there we get into problems. So personally, when you, going back in the slide to emphasize, personally, when you see a patient with a higher FSH and higher LH levels in a patient with a normal ovarian reserve, especially when you see a patient with higher LH levels, promise me, I have seen 2 such patients in my private, and one was empty follicle syndrome. Other one was having an FOA. She is supposed to start with 12 and she ended up with 4 oocytes and 2 embryos. So a higher gonadotropin suggests on day 2, and I had a bad experience with higher LH, but only 2 patients, I cannot generalize these statements. But still, if you have higher gonadotropin in a patient with normal AMH, normal F1, why is FSH going high? Okay, you can blame the labs. If you repeat day 2 FSH, still it's showing a high FSH and LH. So you have to be extremely careful with them. So what to do ultimately at the end of the day? At the end of the day, we should know what to do, not telling about all the research and theory, because suppose if a patient is having a poor response to IVF, whatever you tell them, you can't substantiate the revenue. So what to do? So we need to have answers to these problems, and probably we can have some strategies to prevent this problem. So early detection, what I mean to say. So pharmacogenomic approach, the availability is limited. I have already said, even though you are practicing in Western or European, Italy or Brazil, where they have screened many patients, it is costly, and you need to counsel the patient and make them spend for all this. Some patients may not be willing. So, and in our population, we don't have the adequate data still to take this forward to clinical practice. So we have to go for empirical approach, which is more acceptable and more easily practiced. For like a little bit of awareness, so LHCG exon 12, there are some polymorphisms identified by Professor Ramaraju sir, and probably I think he enjoys collaborating with people. You can probably take his advice and like how to go ahead with screening. And if you really wanted to do polymorphisms, anybody can probably speak to sir, and you can probably catch him on mail. And really, sir likes somebody who is wanted to know things scientifically and improve themselves. Okay, leaving that. So, but what is the main aim of treating this? So, somebody says increasing the dose of FSH. Somebody says you follow ART calculator. So I went into this group posidone.com and tried to access the ART calculator. People have told me it is paid, but still I tried to access again, it is paid only. So unless you become a posidone member, but I think it is worth. I think it is worth But again, practically, are you going to follow all these rules is a big probably no. Because once you find a woman is having a low ovarian response, we tend to aggressively stimulate them. So we don't follow positron calculators. But yeah, scientifically speaking, these people have done a lot of research with due respects to them. We need to follow this. So why all this? What is all we are aiming at? It is to improve the number of euploid blastocysts. It's not that we're going to change the pathophysiology and get them totally to normal. See, if you are able to improve the number of euploid blastocysts, the pregnancy rate is going to be high because 50 to 60% of euploid blasts implant across all age groups and all categories of patients. So if you are able to get more amount of blastocysts and not blastocysts, specifically euploid blastocysts, so that's what we need to aim in this group of patients. So keeping this endpoint in mind, we have, these authors have recommended the various strategies. So pre-cycle, so when already you have a patient ready-made who had a prior poor response as per the definition, so consider using ART calculator, which may not be more applicable, which may not be much applicable for us because our practice style is a little bit different, and maybe seniors can comment on this. And genotype screening, which is also right now in infancy in our population. And cancer androgens in selected patients, we all definitely do it. So there is no doubt that we don't do it. We invariably probably, because even the recent Cochrane shows more favor in terms of DHA supplementation. We supplement androgens. Fine. Okay, then specifically these people have stratified these patients, and one strategy is in these poor prognosis patients in group 1, there is younger unexpected poor response patients. If there are no variants detected, this and inverted commas, this may not be applicable to our population because our variants may be different. So they told to increase the dose to 50 to 75. And if FSH variants are detected, you should increase the dose to 75 to 150 to a maximum daily dose of 300. So I know I am sure that we all know the answer. So whenever we find a poor ovarian response in a young patient, unexpected poor ovarian response, the next cycle will be 300 FSH. I frankly admit maybe I may be wrong. People can criticize me, but my dose will be the same thing. So I will not say that I have given 150 and I'll give 225. At least if I give 150, I'll make it at least to 250 or 300. To be very frank, 300. So there is no doubt. And I don't have polymorphism screening. I don't want to take a chance. If the patient is responding too much, I have always option of stepping down, do early scan on day 5 and step down. And they also are very careful in adding recombinant LH in young unexpected poor response patients. And because the dose may not be 300 in their population because they have genotype screening and they have polymorphism screening and they use ART calculators and all that. So they may not go with 300. So they may not go with 150 recombinant LH as well. So the ratio should be 2:1. So they carefully commented that you add recombinant LH in 2:1. So if you're giving 250 of recombinant FSH, you add 125. So now the Pergoveris has come recently. So if you want to add LH in between like 75 or 150, so the Pergoveris can probably help you. Suppose you are giving the recombinant FSH of around 200, then you can Pergoveris will automatically give recombinant LH of 100. So you can give it even manually also. It doesn't also do, but this is one other alternative we have today. And in group 2, invariably it is 300. So practically our management of group 1 and group 2 in terms of recombinant FSH, mostly, rarely if it's a PCO, I don't mean, again, we need to individualize things. But practically, if it is non-PCO, I think we all tend to go to 300 in both 1 and 2. And in elderly, the guideline says go with a FSH increase of 300. And specifically, if you are used to urinary preparations, which we rarely use nowadays, tend to go for a recombinant. That's what this article says. And we need to discuss a lot on this debate, probably come to consensus. And when you're adding recombinant LH in a group 2 patient, means already when you have gone to 300 FSH, and we can add the maximum suggested dose of recombinant LH of 150. In an even coming outside this review, when people have suggested you can go with the recombinant LH of 225 also in selected group of patients where this is a suboptimal response, but let us not get into that controversy here. But for today, it is 150. So, okay, and so overall, the trigger retrieval strategies consider antagonist regimen, consider agonist trigger, and elective freezing in case AFC have more. So if it's a hyper responder, do all these things, and consider PGTA in posidone group 2 if it's an elderly patient, and consider single blastocyst transfer. So again, the present ART guideline doing PGTA may not be suggestible. Okay, but anyway, in specific cases, maybe it can be done. So FSH dose increase. So they such as when there is so general rule is increase of 50 iteration units of FSH in the initial dose would lead to one more oocyte. So this is a general thumb rule they have given. So when they have increased FSH to 225 or 300 in various polymorphisms, they have got a better response, almost similar to a normal responding patient. So that's what these two studies have said. And the initial slow response, this different people have defined in a different way. In this article, one of the studies which is mentioned down, they have taken at least 6 follicles between 6 to 10 mm and no follicle more than 10 mm on day 7 of stimulation, and E2 below 180 picograms per ml. Maybe we can apply this concept to day 6 of stimulation as well. Don't have to go to day 7, because if you go to day 7 and see all that, fantastic definition, but we will not be able to do anything. Rather than that, we can go for little day 5 of stimulation. We should at least see 10 to 12 mm on day 5 of stimulation. Otherwise, still there is probably something is going wrong, and we need to probably adjust or do something. I mean, not in a conventional stimulation, or not in a patient for the first time. Maybe when the patient is having poor response, probably we can do a scan earlier. We can rescue the cycle earlier. So what is all this basically is rescue. Whether you are increasing the FSH dose or increasing the LH dose, so it's basically rescue. And when you're planning to increase the FSH dose, you need to aim at day 1. That's what the previous 2 articles have said. But when you're adding LH, so when there is a slowing of growth in spite of increased FSH, or unexpectedly it's a first cycle and there's a slow growth from day 4 to day 6. Because Professor Peter Humaydan says it is not after day 6. It's before day 4 to day 6 only all the bad things happen in the cycle. Suppose around day 5, day 6, if there is a slowing of growth, then probably we need to add recombinant LH, or I mean, this article doesn't mention HMG, maybe they promote LH, I mean, I don't know, but we can add any form of LH to rescue the cycle, because if that slowing happened, the effect is already made, then whatever you do probably may not rescue much. And there are different doses of recombinant LH mentioned, 75 to 150, but 150 is more appealing to start, and 75 can also be started according to some studies. So double stimulation or a dual stimulation is something which we need to, when you go, I mean, articles definitely say that they've got comparable fertilization, comparable blastocyst, comparable euploiding, comparable pregnancy rates, and similar oocyte competence. Almost they say the luteal phase stimulation has got a more number of oocytes compared to follicular phase stimulation. But if you ask the question why instead of going for one more cycle, why we need to go for a dual stimulation? So the answer is the ovary is already in a stimulated state. The follicles are almost already driven very hard. So like we know that follicular recruitment happens in waves, not in day 2 of cycle. It happens in waves through the cycle. So because of the high FSH we have given at physiological level, so all the follicle waves have been pushed so hard, and we have a lot of follicles which have been recruited. So it is at this phase that the second stimulation can throw some more follicles compared to the first stimulation. Because the ovary is already sensitized and very much stimulated, the second stimulation can give a little bit more benefiting effects. That's what is my understanding of it. So that's probably why in the luteal phase stimulation, the follicle numbers can go a little higher compared to follicular phase. So even Cochrane has favored that DHEA supplementation can improve the outcomes of ART, and it can increase the live birth rate, and it can decrease the miscarriage rate. It should be given at least 8 weeks and ideally up to 12 weeks prior to ovarian stimulation. So what exactly, how to approach these patients? So infertile patients undergoing ART may have poor response, suboptimal response, and we need to first identify them. And Again, we need to, when you know that patient has responded poorly or with less than 4 oocytes or suboptimal with 4 to 9 oocytes, we need to think about two things, whether they're younger or older. If they're younger, they are group 1, they're older, they are group 2. So leave posidone. It's for our understanding also. If they're younger, we need to treat them in a different way, and older, we need to treat them in a different way. So because age also plays down this ovarian response apart from polymorphism independently. That's what we need to understand them. And then we need to apply FORT and FOI. So how many follicles were there and how many have given. And ART calculator may not be applicable in our population, or if you want to apply, we can apply and see how it goes on. So what are suggestible interventions in them? Use of recombinant FSH preferable to urinary as suggested by these authors. Increase the FSH dose to 225 and sometimes up to 300, preferably 300, unless it's a hyper responder. Use of a recombinant LH and androgen supplementation or any form of LH supplementation should be given for these patients in androgen supplementation, dual stimulation depending on your preference. Thank you.
Thank you, Siddharth. Nice article, nice presentation. Can you hear me?
Yes, ma'am.
Okay. Yeah, they've really dealt this means topic very nicely, you know. So what I understood is almost 50 or 60% of the population falls into one of the Poseidon groups, and the rest only will are either normal responders or hyper responders, or at least known responders. We know what response that is, and in that 50%, I think quite a lot of them are in unexpected poor response, and unless we understand this concept, a lot of times we think that okay, this cycle, I don't know what happened, my drug did not work, or I did something wrong, or Stu did something wrong, and somebody didn't give the drug properly. We blame the sisters, and you know, it goes on, and then anyway, like you said, the next cycle we'll be doing the same. Sometimes we do the same, sometimes many a times we increase the dose or add LH, and without knowing, we were treating these patients in the same way. But if we can understand why it is happening, and there is a definite subset of patients where there is a good number of antral follicles, and you start stimulating, and you don't get so many oocytes, or so many oocytes like FOI. So it is, but actually, if we are doing stimulation scientifically, I think we should apply this FORT and FOI for everybody. We should have our AFC, and then if that is not happening, okay, there is the stimulation has gone wrong. There could be, like you said, there could be different reasons for stimulations having gone wrong. We could have given a wrong dosage, like less dosage, or there is a lot of asynchronous asynchronity, or this one of these polymorphisms. And all these reasons, because of these reasons, we might be getting less number of oocytes with when compared to the number of antral follicles we start away with. So they have discussed quite well about FSH. FSH polymorphisms, FSH receptor polymorphisms, and a lot of people are joining now. Receptor polymorphisms and LH receptor polymorphisms. And even I had the opportunity to be with Dr. Ramaraju for a few days. And they very regularly, and he believes in this pharmacogenomics. Instead of discovering who is this Poseidon 1 and 2 on day 6 or on after picking up, you know, after that, sometimes we see the follicles, but we don't get the oocytes. So that also comes in, you know, we may find some 15 follicles also, and we may be getting only 4 or 5 oocytes. So that also comes under this group only, where like as long as your FOI is not good, it comes under 1 and 2 based on the age. You agree, right? So we have to calculate FOI for each and every patient, and if they are not, it is not falling in the normal range, then we are looking at either Poseidon 1 or 2. So when we are looking at Poseidon 1 or 2, either we are giving the wrong dosage, or we are giving the a lot of asynchronity. So we have not synchronized the follicles, or we are giving wrong trigger, or there is a polymorphism. So we have to look into all these factors, and then try to see if we can rescue that in that cycle itself. So that, because a young lady comes and then you see so many antral follicles, you are confident and you tell them that, okay, I'm going to stimulate and you're going to get so many this thing, and you give all the percentages, and then on day 7, day 8, you won't know what to say. I'm sure all of us have faced that. So if we can do something in that cycle itself, you don't have to cut a sorry face. And that is where this dual stimulation comes into play. And you have 15 antral follicles, you stimulate on day 7, day 8, day 9, we have only 4 or 5 reasonably good antral follicles developing. I would go ahead and take them out, and then start the stimulation immediately, and then tell them that she needs some more stimulation. So that is easier to tell, rather than canceling the cycle, or tell them that this our stimulation did not work and then she needs one more stimulation, give a gap of 1 more month. So that is I think that cuts away, that gives a very negative message, I think. So dual stimulation works really well in rescuing this Poseidon 1 and 2, I think. So yeah, and like Ramaraju, if you can do a polymorphism for each and every person you are stimulating, like routinely he does, like we do thyroids and sugars, he does polymorphisms.
Right.
And if they are present, and accordingly he will increase his FSH dose or add LH, and that he says that is how we will be going in future, and that is pharmacogenomics. But like you said, he has taken 10 years to arrive at the polymorphisms in his population. What is if it is so variant, if as you say, if it is but when I asked him, he said in South India you can depend on his polymorphisms, but you're saying we can't. Then if Vizag is one polymorphism, Salem is one polymorphisms, and it will take our lifetimes to design the
multicentric problem. We have to do studies in many places and see.
Yeah. So I'm sorry, I'm only commenting. Anybody else wants to comment? Dr. Nandita, ma'am, hi.
Hi. Actually, I do polymorphism for all my patients.
Okay.
And I've been doing it from 2015 onwards.
Oh,
so it's easier to subject them then, and then probably identify those who require high FSH dosing or LH, because they now have come down to even LH polymorphism, FSH polymorphism. And if you see, mostly it is the serine and tryptophan or something. Those are the junctions which are lost. Or it is something, the number of polymorphism points are down by even 20. They're studying how many points are deleted. Now they've gone into that level of study. So if you find high amount of depletion in the junctions, they are the ones who require high FSH, or, they get, the ratio is totally abnormal. So it's really helped in my practice. The cancellation rates are much, much lesser. And probably the oocyte recovery is slightly better. It has helped. I mean, I would like to hear from others. I've sort of made it a norm, because, instead of giving a whole cycle of, 50, 60,000 rupees or 80,000 rupees drug, adding a 6,000 or 8,000 tests should not really, change the scenario.
What is the cost to the patient, ma'am?
It was till about pre-COVID time, it was around 8,000 rupees. But if you're doing it through the center, you can, ask for the reduction and give the reduction to the patient. I transfer that reduced amount to the patient. So I don't actually charge that. So it was working out to around 6,500 or 7,000 rupees.
What are the polymorphisms to be checked? Which lab do you send?
See, I sent it to Dr. Vani and Surat. They have a Swagene center, which is here. And I've been working with them for almost like 6-7 years now. Even in male, I have done where, the male has got a low count, and then they are the ones who respond even to the FSH-LH therapy injections. So I worked even in that sector, a small number, not a very big number. We with Dr. Suraj, I've done even a comparison between international data here because he has worked in the UK. So what is the type of gene there and what is it different in the Indian population? He's got a lot of data. Probably, we can call him and, talk a little more on this. A lot of things might go over our head, but I think it's really worth taking note of it.
We'll definitely call him. How many genes do they check, ma'am? How many genes do they check? How many polymorphisms do they check?
They do 3 at the. I mean, they were doing 3 earlier, but now I think they've increased the number of FS because they found the mutations are more. For Indian population, they keep evolving the number of genes that they have to test.
Okay. Very interesting. Very nice. So and what do they say? Will they say they have polymorphism and they don't have polymorphism, or
so what they do is they study. So for example, if it is FSH 1, 2, 3, that 06, that number will be there. Then they will study those 3 levels or 4 levels, and they'll say this patient would require higher dose of FSH compared to normal because of the mutation present. Or if there's LH, they will say that. Then even clomiphene resistance, they will, like Siddharth mentioned in his talk. So clomiphene resistance is also brought about. So people who want to do tablet with injectables, where you, then the clomiphene will never work on them. So this is as far as what I have observed.
Very nice, ma'am. Anyone else wants to comment?
Good evening, madam. Dr. Nandita.
Chandra, madam.
Yes, after seeing this polymorphism and all, madam, you have found a better oocyte retrieval and all, madam?
Yes, definitely the oocyte retrieval is much, much better. Okay, because you're going to hit at a high dose. It might be a young patient. As Siddharth said, the only indicator is high FSH. Or it will be the PCO with a high LH, or, depending on your Poseidon classification. As he said, 1 and 2 are the biggest challenges that we face. So it really helps. Oocyte is better. The number is definitely better recovered. Whether pregnancy rates have improved, yes, probably very marginal. I would not say very significant because there might be other inherent problems. But definitely we don't cut a figure saying, oh, I didn't get eggs or the number of eggs were very less. Rather than going for a dual stimulation or something, hit it off in the first cycle itself, if possible.
Ma'am, could we, sorry, this is Dr. Praveena here. Ma'am, could we take this thing that you said about the clomiphene resistant group of patients? We could well identify them when we are doing stimulation for the IUI cycles also. Because usually the younger patients, we tend to start with the IUI cycle, seeing the AMH is better and when all other factors are favorable for IUI. So even we can pick them up as early during that time itself so that we don't get the disappointment after converting them to IVF. The first cycle is we don't have to waste that first cycle. Am I right here?
I have not done IUI. Anybody else can tell. But IUI, normally now we put letrozole as the first line of medication. I think most of us do that. Hardly, very few of us do clome as a first cycle. If it else,
on the spectrum, the polymorphisms will be accounting only a minor portion of that. Because clomiphene resistance, we all know in PCOS patients have many reasons why clomiphene resistance will happen and what to do. Maybe it may not be cost effective doing this polymorphism because not all people may be having this. Because they said in their days, because those studies are focused on polymorphisms, they said their main aim was not clomiphene resistance in polymorphism. They incidentally, when they're doing this, they found that some people had clomiphene resistance. So maybe not.
How is it justified in doing as a routine test for all, ma'am? Like this is something happens around 10 to 15%, and Can we advise this in the first visit when we are doing the day 2 bloods? We can't ask for a polymorphism because polymorphism happens, the is very less when you order, you need to have the incidence and prevalence more for you to do in the routine workup. So it is so less. How can we say that we could spend 7,000 to 8,000 on that? I mean, I don't know if we can routinely do for all the patients. How do you convince these patients, ma'am? What do you tell them?
Like I just tell them this test is available. It will tell us whether your requirement for your injections would be higher or you can take the normal dose. It takes a little while to explain to them.
Yeah.
80-90% agree to it because they are quite desperate. But I really not put it out into our public domain and say every patient needs this for us to talk about incidence. We are choosy because we have only that group of patients where we are, showing a low retrieval when we look at the follicular number. So we are actually, selecting our patients to do the test. It's like, when we started antagonist cycles, we only chose in failed patients or this group. Now we use antagonists for all patients. So it's something very similar to that. We are in that situation today.
Yes, and pharmacogenomics has come here to stay. And in oncology, they are using it and they are getting such a good results. So in our field, it is a little bit slow, probably because there is so much variability in these genes. If there is a test which tells us how much FSH to start and how much LH to start, or whether to give the LH and all, I am very much willing to spend that much money, because it's how we convince the patients. And if we tell them that we can tailor make the stimulation for you so that your chances are better, and I'm sure they'll be willing to spend that much money. But because of so much variability, I think it is not picked up. Probably it's my take on that, but
I second that point with you, ma'am. Initially, even I thought, how can I convince my patient? But over time, when I started implementing as a part of my routine, because most of the times those who come to me are, failed somewhere. That sort of clientele come to me. So I think that's a good option to start with. Probably when you start seeing and doing more, we'll get more numbers to speak about.
I saw Mona. Mona, hi.
I joined late, sorry. So I thought at least I should be with your discussion with you people. And anyway, I will hear the recorded. I'm sorry for that.
Yeah, it's okay.
But see, these are all retrospective. I mean, very rarely you can, only if we do routinely for all, we will come to know. But how much it is feasible to do for all the patients, I'm not sure.
No, you read his article, Ramraju's article. We keep saying Ramraju because he's the only person who has done so much study. And honestly, like we do thyroid and sugar, he does this, and then
that is because, madam, that is because he has got a sequencer, everything in doorstep. Not only having sequencer, he has got 2 PhD people, postdoctorates rather, constantly working on that.
No,
and whatever he wants to create a primer, suppose tomorrow morning he wants to test one locus, they will ask his assistant to prepare a primer 1 week before, and then they will test. So they have that much flexibility, and they charge only 500 rupees, 600 rupees for polymorphisms and all that. So then that is a different environment when he practices.
No. Okay, he has done all that to arrive this, because he's got his own genetic lab and his own PhD people, and he has studied so many genes, and then finally narrowed down to he studies 6 genes now, 3 for FSH and 3 for LH. And what I'm saying is, in his routine clinical practice, he uses this for every single patient to tailor the FSH dose and LH dose. But if I don't know, if you tell me that the Vizag, between Vizag and Salem, there is not much of variability, I will jump and use it for everybody.
Because once he asked simple, like how to recommend LH, that those days he was more focused on LH. He was telling if it's AA, no LH, AG 75, GG 50, 150. Yeah. So as simple as that, but it's not simple. But He says that's a basic understanding.
When you have, they have done 10 years of research to simplify for you, no?
Yeah.
So they have identified one particular gene on the LH receptor, which is more close, which affects your stimulation. And if there is, like Nandita Thakur madam said, and if there is a replacement, she gives a higher FSH dose. No, one amino acid replacement only, she's giving higher FSH dose. Similarly, in LH receptor also, if there is an amino acid change, you have to give, if it is homozygous and heterozygous, you have to give half LH, and homozygous, you have to give the full LH, means higher dose of LH, like 2:1, something like that. So it is nice. Only thing is this variability between the across the population, that is limiting our its use in our practice, I think.
Dr. Vani, can I add one point? I'm Dr. Radha here. Sorry, I joined late.
Yes, Dr. Radha.
Yeah. I slightly differ with what Dr. Siddharth is saying, because in Vizag, I don't think he's dealing only with the population from Vizag. He's getting population from across the country.
Yes, right.
So I don't think we can say that there is a geographical variation.
Okay.
And one more thing is, one of our MCH postgraduates is also doing a study on LH receptor polymorphism. We are sending the samples to Vizag.
Okay.
She is taking a sample for all the patients who are undergoing stimulation, and she's sending the sample, but we are not adjusting the dose. We are just doing a study and seeing what is the requirement of the dose. Probably we may publish it in a year, within 6 months or a year. So we will see that even we are getting people across the South Indian population.
Yeah.
So probably it may not be like from Salem and Vizag. It might be different. It may not be to that extent.
Yeah.
Probably we can use it in the long run, the later part of the coming the generations, because by that time I think we will get some clear idea. And especially doing that in a small resource setting, it might be difficult. So if we have some place where they can do this routinely, then probably the number of cases might increase. So in ours, we have been collecting the sample almost for nearing more than a year now.
Oh, good.
So probably when we analyze the data, we'll be able to get that information.
I think this Dr. Raji is asking a question. Do you want to know for rescuing the 1 and 2 for dual stimulation or routine dual stimulation? Dr. Raji?
A routine, ma'am. Routine dual stimulation.
Routine dual stimulation, the same dose.
Same dose.
Rescuing, obviously, you have to go up. Because first cycle you haven't got. You know that your dose is less and you have to go up on the dosage. So if you are doing a dual stimulation, and you go up on the dosage.
Okay, thank you, ma'am. Thank you.
But dual stimulation, even I'm a bit skeptical about the message what they have given. When you know that your FOI is good, your dual stimulation could be, but when you already know that if your FOI is not good, maybe even while doing a dual stimulation, we need to tell the patient, we'll try with the high dose, but still we are not sure exactly what's going on.
It works, Siddharth.
Definitely it works.
I've tried, like we see so many antral follicles and start giving 150 or 200, and then and on day 6, day 7, and there is very few follicles growing, just 4 or 5. When we have this thing of about almost 20, it happened quite a few times for me in so many years, of course. And I just continue the same dosage and pick up those follicles and promptly start 300 the next cycle. So I'll get about 15, sometimes even 20 follicles also in the second cycle. So I think if there is a drastic difference in your fort, there is a, then you can use it. If the fort is good and FOI is not there, and it will be a little bit messy because there are so many follicles there, we don't know which one is growing, kind of. If your fourth is bad, it'll be very easy to stimulate second cycle with a higher dosage. Means in my personal experience, I'm saying. Anyone else wants to say anything? Kavitha?
Ma'am, good evening.
Hi, yeah.
Nice discussion. I was just listening. Sorry, ma'am, I couldn't see. I mean, the first 30 minutes I was not there.
Okay.
So what I do, I may be wrong. You can correct me, ma'am. We can do either whatever polymorphism it is. Yeah, we can either increase LH or add LH. Why can't we add LH right from the beginning? That's what I do. At least 75 of HMG. I don't use recombinant. 75 of HMG. And definitely recombinant also will be there, of course. And if you're doubtful, I think previous stimulations will guide us better. If 4 or FOI less than 50%, what molecule they have used, then we can do the opposite. If they've used only FSH, add HMG. Or
Yes,
we can increase the dose of FSH. We can
Let
play
me
around.
clarify on that, madam. So here they have clearly told this article, when you're using LH as a cycle rescue, then you need to add in the mid follicular phase. Means you didn't anticipate something.
No, I'm asking. I do it from day
in the
2
second
itself.
cycle,
I
you
start
should
together.
add from day 1.
Yeah, that's what
the
I'm
authors
talking.
have clearly mentioned it. You
No,
should add
that's
from
what
day
I'm
1.
talking. Like both I add together right from day 1. 75 of HG, all my patients will be having. So even if it is LH polymorphism, they say either 75, max 150 of LH, right?
Yes.
Yeah. So when you have added 75 and your expected response is hypo response, then you can increase FSH, right?
Yes.
Yes. And we have to do it little earlier, not on day 6, day 7. Day 5 or day 4, if you are doubtful, if the previous stimulation shows hypo response, please see early and increase and play around with the molecule early. Other two molecules, what these people have mentioned, one is testosterone therapy, right? And the other thing, what I really believe in is growth hormone. I don't know how many of
growth
you...
hormone is not mentioned in this article. Because
I'm saying
this discussion to journal.
I went through the article. Growth hormone is not mentioned in this.
Yeah, I personally use growth hormone, madam, and really it works. For some cases, it works.
So maximum you have given, and both the molecules you have used, add growth hormone, then it works beautifully. That's what I have seen.
It works very well. And as you said, I tend to add HMG very more. I mean, I have a tendency to add HMG even. I mean, it's the first stimulation. So these are all our personal preferences. Maybe because it's scientific forms, I don't want to get those controversies here. But actually, as you said, even I think I asked Kannagi madam some days ago in the same journal club. She said whenever she used to batch previously, routinely all of her patients will be on that 3:1 or 2:1 HMG. But nowadays, after this ANTA has come, she had little change. I mean, change her protocols and all that. But she says it is never wrong to add an ample of HMG if you at all you don't want to anticipate surprises.
It's not going to harm any of the clients.
That's what she said. Yeah, it has been a very good advice for me especially in my initial days of practice.
That's what I follow for everybody.
That's very nice practical strategy, man. Very nice.
Yeah, if we have a previous cycle, there is nothing like it. A good cycle, bad cycle, everything is useful. But if you are going in for the first cycle and you want to be perfect, then this pharmacogenomics comes in. Right.
Ma'am, I don't know, like lots of new things are coming up. Once, like all of us were into ERA, I think now most of us are not doing. I have never done. I'm just saying, okay, so all these things just adding up cost. Instead, we can play around with the drugs. Finally, that's what we are going to end up doing.
Yeah.
No, this is, see, we can always do this, but this is having a basis of adding. I mean, just understanding the why we are adding and why we should increase. If you want to understand and add, I mean, this is what has brought out. Till then, everybody were scared of adding LH. even in a PCO. So this is all these studies have brought a change in our understanding. So that's how this study is useful. So now, because we have this background knowledge, we are directly using this instead of spending for an investigation.
Yeah.
So maybe we can use it, but if you really want to understand how it's going to use, we can spend on testing for all this polymorphism.
Dr. Nirmala, hi.
What is your do you routinely add HMG in even normal responders in the first cycle?
You're asking me?
Yes, ma'am. Just know your experience, because that will help us more compared to all these articles and all.
No, I don't add routinely.
Yes.
I don't add routinely, and I look for some reason why this lady, and I am doing polymorphism testing with Dr. Ramaraju for few patients. I do spend quite a bit of time before I start my first dosage. That is when I spend
That is ideal, ma'am. That is ideal.
That is when I spend all my time. After that, in fact, I can neglect the cycle also, and I can depend on my staff also. If I don't scan on a couple of days, I know what is going on. So when we spend time on the initial phase itself. So if I find some reasons why this lady might not respond the way she should be responding, you will get to know a lot of things. Even endometriosis and all those things, and the way she has been behaving in the many years she had infertility, and when you just give a letrozole or a clomiphene, how she's behaving, with lot of follicles or very less follicle, and she didn't respond at all for a few cycles. So all that gives you a lot of input. So if I do all that, and then if I add LH, otherwise I go straight with FSH, and if necessary, I add LH in between. But routinely, I'm not giving yet. But few people, I can't figure out how much to give and what to give, and those people I am testing. Polymorphism testing with Ramaraju sir. So if they'll give it in a week, and if anything,
how is that packing the samples? Any special precautions to be taken while packing the samples?
I think it's CDTA, and then you send it off, and within a week I get a mail from his geneticist. And if I have if we have any doubt, we can call and talk to sir also, he'll explain. But it's
so far, like how many polymorphisms we've seen in our subpopulation? Whatever tested.
No, I don't have a huge data. Like I said, I'm little bit skeptical in testing everybody, because I'm to a certain extent, like I've used like over a period before I got to know these polymorphisms, I developed my own intuitions and additions, subtractions to decide on the starting dose and deciding on whether I should add LH or not. So I'm still following that. But this polymorphisms, I'm just trying to add into my practice. I would have done maybe around 10 people or so far. And in that, 3 people had polymorphisms, 1 FSH and 2 LH polymorphisms. So I was happy. I don't know, maybe I would have straight away put them on 300 FSH for them. I don't know. But with this, I didn't have to think. I straight away put them on 300 FSH, and for this thing, I didn't use our recombinant LH, where sir uses recombinant LH, and I've started on HMG only, 150 HMG I've added.
Once if we switch over to Pergoveris, there is both no, ma'am, right from day one.
Yeah.
Yeah.
Yeah, we can give Pergoveris for I don't know whether it is because either you mean to say why to bother about polymorphisms, use Pergoveris from day one.
I had only one advantage. What I was seeing probably with Pergoveris is, suppose you are finding in group 1, you don't want to give 300 FSH, you want to give little lower FSH. and you want to add LH proportional to FSH. Maybe you are giving somewhere around 225 FSH instead of 150 or something, because we don't do that, but maybe the automatically LH gets adjusted. If it's 200, automatically LH will be 100. Maybe otherwise we have to take manually C and take exact quantity. And all. Otherwise, I'm not sure it is. Don't know.
Yeah.
Maybe for that reason they must have launched that. But we are actually comfortable with 75 or 150. You're saying a pharmacogenomic sir will give either 75 or 150 numbers. So
when you do too many tests and when you are picky, you want to decide how much FSH to give and how much LH to give, rather than go with the standard dosage. But I think they have designed this Pergoveris for Poseidon 1 and 2.
Poseidon, yeah. More so one that Poseidon 1, which they don't want to give 300. They want to give a little lower, even though they are Poseidon 1. But we generally follow either 75 or 150 if you want to add it.
Okay, so anyone else wants to say anything? Indu? Indu has left, I think. Okay, thank you everyone. Thank you, Siddharth, for the nice talk and discussion. We'll close the session.
Ma'am, end பண்ணிட்டுங்களா?
பண்ணிடுங்க.
Thank you.